Today, I'm going to present on supplementation, and this is a topic that is not new to any of you, but I wanted to just capture some of the pieces of supplementation, and we can have that to be able to share with facilities and learn from each other. So, the objectives for today really like to review quickly the infant feeding recommendations and a couple of definitions. We're going to discuss ways to prevent the need for supplementation, review indications for medical supplementation, um, and if we do need to supplement, we're going to review careful supplementation, documentation of supplementation, and then discuss briefly parental or personal supplementation. So just to capture for everyone, the World Health Organization and UNICEF do recommend that children initiate breastfeeding within the first hour of birth and be exclusively breastfed for the first 6 months of life, meaning no other foods or liquids are provided, including water. And for the purpose of our presentation today, I just wanted to share exclusive breastfeeding being defined by the Breastfeeding Committee for Canada as the infant receiving human milk, including express milk and donor milk, and allowing the infant to receive oral rehydration solutions, syrups, vitamins, minerals, or medicines, but doesn't allow the infant to receive anything else. And as far as a supplement goes, when we're talking about supplementation, this is defined as any oral fluid, except for the vitamins, minerals, and medication that other than human milk that's given to a breastfed infant. So, step 6 of the 10 steps of successful breastfeeding really focuses around supplementing. And so, that is to support mothers and parents to exclusively breastfeed for the first 6 months unless supplements are medically indicated. So, that's part of our role for those who work in acute care that we support mothers to breastfeed by really giving only breast milk unless there are medical reasons for supplementation and by prioritizing donor human milk when a supplement is needed. And so we're going to look at those medical indications, but really focusing first on prevention is key. And the 10 steps to successful breastfeeding really help support that prevention of supplementation. And so I plan to talk through some of them and talk about how each of those steps can help us to prevent the need for supplementation and and really focus on supporting that exclusive breastfeeding. And so it starts right with those hospital policies. And we think about the policies that we have in place within our facilities that support exclusive breastfeeding. That piece is so important. Staff competencies. So knowing that staff have the ability to support women who are breastfeeding while they're in our care can really help to prevent the need for supplementation. If staff are aware of normal infant feeding behaviors, if they know how to support women with latch position, and effective milk transfer, that does help to reduce the need for supplementation. All staff that care for pregnant and postpartum women should be able to assist with breastfeeding, and that's all falls within that step 2 of staff competency. Antenatal care, and I think that when we think about this piece of it, we're often thinking of antenatal care as teaching women and families the importance of breastfeeding and the process of breastfeeding. But I think anticipatory guidance, as far as what they can expect for the baby in those first few days of life, are really important. Discussing, cluster feeding in particular, and giving them that support antenatally so that they know what to expect when the baby's born and that they know what those normal feeding behaviors are. I think a lot of times when we look at parental or personal choices to supplement, if we had provided that anticipatory guidance antenatally, we might see a lot less of that supplementation. Step 4, the care after birth, and facilitating that uninterrupted skin-to-skin contact at birth, helps pregnant women, and families to be able to provide that skin-to-skin care and have the baby initiate breastfeeding, as soon as possible after birth. So those healthy term infants, if they're placed skin-to-skin with the mom, if she's awake and alert, then they can start breastfeeding as soon as they start to look for it. And we know that there is research would show that a delay in the time between birth and the initiation of the first breastfeed really predicts the use of infant formula. And so to delay that first feed has an impact on the need for supplementation. And so supporting that skin to skin within that first hour, continuous uninterrupted skin to skin, has such a great impact on exclusive breastfeeding. step 5, so talking about, supporting and educating mothers on how to manage breastfeeding, also very important, and rooming in, having babies in constant contact with the mother or their family, and having families learn to read their baby's cues, and instant access to be able to breastfeed when babies show those early feeding signs, also very important for supplementation. And steps 8, 9, and 10 are also relevant, but I thought just for the purpose of our presentation today and for the time, we won't go into those in any more detail. So prevention is key. We know that. However, as much as we can identify risk, and I think part of our role in acute care is to identify risk for supplementation, and try to proactively support that. And all of these indications for medical supplementation that we're going to review, some of them, if we know in advance that this family is at risk, due to this particular reason, we can support that family even more. So, for example, families that we know the pregnant person is gestational diabetic, for example, we can really work to support that family with antenatal colostrum collection, early and often breastfeeds, and that will help to reduce the risk of the baby needing that medical supplementation. So, with prevention, we know that we can work to reduce the risk of supplementation, but really there are some cases where these babies will require medical supplementation. And so the BCC has a great resource that you can use and share with your facilities as far as what these different conditions are. And just to go over a couple of them, if we think about some infant conditions, so there are definitely some infants who should not receive human milk, or any other milk except very specialized human milk substitutes. And so those would be babies that have the classic galactosemia or maple syrup urine disease, which I feel are very rare, thankfully. Also, babies who for whom human milk remains the best feeding option, but they might need other food in addition to human milk for a limited period of time. So identifying those babies and making a plan with the family is very important. So some of those reasons would be, for babies born less than 1,500 grams, babies born less than 32 weeks of gestation, any signs and symptoms of inadequate human milk intake. And, from previously working in acute care setting and knowing how this can be misinterpreted, I think, these guidelines have very clear criteria for dehydration. Um, any, growth faltering at any gestational age specific to growth charts, persistent jaundice from a lack of intake, with ongoing weight loss, limited stools and uric acid crystals in the urine. So those are some reasons why we would want to add, in addition to human milk, a medical supplementation. And then there's also many reasons for the mother or the birthing parent. So conditions that might justify permanent avoidance of breastfeeding. And so these would be things such as HIV, and T cell lymphotrophic virus, type 1 or type 2. Um, Also, we look at conditions that might justify that temporary avoidance of breastfeeding. And so it's not to say that this family won't be able to continue to exclusively breastfeed, but there may be times when we need to do that temporary avoidance of breastfeeding. So, for example, if the mother has intolerable pain with breastfeeding, despite any ability, assessment and ability to try to resolve that. And that would require a thorough assessment by a healthcare provider that is very knowledgeable in supporting breastfeeding. Severe infant. So, there are times when we have a family where the mother is admitted to ICU and is very unwell after she delivers, and in which case, she may not be able to exclusively breastfeed. I think in those cases, it's very important for us to, make sure that we are not making those decisions for the family. I think sometimes we think, oh, she's so sick, she won't be able to breastfeed. But maybe that's the one thing that she feels like she can do for her baby. And so, really giving that decision making ability to the mother when possible is very important. Herpes simplex type 2, if there is an active outbreak, um, and you know active varicella, so we can give breast milk until the mother's no longer contagious. Give express breast milk, sorry. And then if there is any contraindicated medication, so certain sedating psychotropic drugs, anti-epileptic drugs, opioids and their combinations that cause side effects such as drowsiness and respiratory depression are better avoided if there's a safer alternative available. Radioactive iodine, um, given that safer alternatives are available. And then certain chemotherapy drugs as well. Looking at the final conditions, that's where breastfeeding might continue, but there might be some health problems of concern. The infant may require additional intake. So if the mother has delayed secretory activation or that onset of lactogenesis 2, there's not a sufficient milk supply for the infant intake. If there is a primary glandular insufficiency, certain breast pathologies or prior breast surgery that results in poor milk production, a breast abscess, where she can continue to breastfeed and give express breast milk from the affected breast. Hepatitis B, so those infants should be given hepatitis B immune globulin and hepatitis B vaccine within the first 48 hours as soon as possible thereafter. Mastitis, so really encouraging the parent to continue to breastfeed and give express milk from the affected breast if she is not able to latch the baby to that breast due to pain. Um, and then, certain substance use. These families should be encouraged not to use substances and to provide opportunities and support to use appropriate harm reduction strategies. So when we look at all of those different medical indications, it's important that they be assessed by healthcare providers with the knowledge of what those conditions are and how those families can be supported. And recognizing that even if there is a need for medical supplementation, to, try to encourage as much breastfeeding as possible in the conditions that allow for breastfeeding. I had a parent who um, gave her story on when she was really ill after she had her baby and she wasn't even offered the chance to breastfeed. And I think that that one really resonates with me, that sometimes as healthcare providers, we make the assumption that somebody, because they are sick after they've delivered or during the course of their breastfeeding, that's probably not best for them. And I think it's so important for us to always allow them to decide what's best for them. And this particular mother felt that there was nothing that she could be doing for her baby because she was so sick, but she felt that she could breastfeed. And that was so important to her. So once we've decided that we have to supplement due to medical reasons, supplementing with care is so important to preserve that breastfeeding relationship. So the choice of supplement is important. First choice would be express breast milk from the infant's mother. If that is not available or there's not enough of that available, then we would seek to use donor human milk. And if that's also not available, then we would rely on human milk substitutes such as infant formula. The volume of the supplement is also really important. And we know that, you know, depending on the gestation and the age of the child, this is going to change. But keeping in mind that the volume of the supplement should be, enough to make to improve whatever the condition might be. So, for example, a baby with hypoglycemia that's not responding to breastfeeding, what amount of supplement is required to bring that baby's glucose levels within normal ranges. We don't need to give excessive amounts of supplement, but just enough to make a difference. Also keeping in mind, what would the baby be normally receiving at a feeding at this gestational age? So the belly size of the baby, how much colostrum they would typically take at the age that they are, and really being mindful of not overfeeding. The goal is to get back to exclusive breastfeeding, and if that volume of supplement is excessive or the baby is overfeeding, they won't be satisfied with the normal volumes that they should be receiving. The method of supplementation is also really important, and there are many different methods available, and every I think the key piece is that we want to make sure that the supplementation is meeting the needs at the time, and so um, the delivery methods that we can choose from. So there's supplemental nursing systems that we use at the breast, cup feeding, spoon, syringe feeding, finger feeding, and also bottle feeding. Um, these feeding devices, there's pros and cons to all of them, but in each situation, there are some things that you can, look at to see which is maybe the best method in this case. Obviously, the cost and the availability. Supplemental nursing systems can be very costly compared to a syringe, which is usually available in any hospital facility that might be caring for babies. The ease and the use of cleaning. So if you're sending families home with this, do they have the ability to use it themselves? Can they clean it properly? Is um, is the baby going to be able to take in an adequate volume of milk, over a 20 to 30-minute period of time? And depending on the volume, is this something that can be fed in a syringe, or is it a larger volume and it needs a cup, or the supplemental nursing system, for example? Is this use going to be short term or long term? So if this is going to be a one feed of supplement, we think, and then baby's going to be going back to the breast, that's very different from is this going to be, for the next number of days or even weeks that this baby is going to have to be supplemented. That will affect the decision on how, which method you choose to use. And what is the mother or the parent's preference? Do they prefer to use one method over another, and how do we support them in that? Are the staff trained to use these things? We want to keep in mind safety, and if the staff that are caring for this family are not familiar with the supplemental nursing system, for example, you would want to make sure that they had that competency before selecting that method. And you know, does this method really support getting back to exclusive breastfeeding if that is indeed the goal? And we know that, a lot of times we are going to have to use a bottle for these supplements if other methods aren't available, or, parents choose to use a bottle for the supplementation. Um, and babies often can develop that preference of the flow of the nipple. So just thinking about, does this method really support exclusive breastfeeding if that is the family's goal? Also keeping in mind that it really depends on the baby themselves, and how, are they a little prem who hasn't been able to effectively latch yet? In that case, you may not choose a supplemental nursing system. Um, or if the baby's not hasn't been latching at the breast successfully, um, they may not be able to remove that milk with the supplemental nursing system. So there are other choices would have to be made. And so taking that into consideration as well, that this baby is actually going to drive the decision a lot of the times. Um, I think the ultimate goal with supplementation always needs to be protecting that milk supply and encouraging that family about the importance of removing the milk if the baby is not removing the milk. So, of course, if we can put the baby to the breast and then supplement, that would be ideal. But if the baby's not able to go to the breast, or we are supplementing because breastfeeding is contraindicated, for example, and that mother wants to continue to breastfeed down the road, it's really important for her to know that she needs to be removing that milk as often as the baby would be feeding, at least 8 times in 24 hours. Encouraging that nighttime pumping and expression is so important, and giving her all the education um, and support that she needs to learn how to hand express, to learn how to pump her milk, if that's what the plan is, and then how to store that breast milk as well. So much education and support is required so that families feel the support to protect that milk supply during times of supplementation. I know we talked about Kathy doing a more in-depth presentation on documentation at a future date, but just wanted to include this so that we are aware, these supplemental feedings, it's so important that they're documented, not just for capturing um, our data for BFI purposes, but really just to capture for what this baby's intake is nutritionally. So we should include the content. So what are we feeding? Is it express breast milk? Is it donor milk? Is it an infant formula? The volume of that supplement is also important. How the supplement was given, and what the reason was. Was it medically indicated, or was there some other reason? And so how you can capture this in your charting makes such a difference when you go to look for that data down the road to capture your rates. And so some facilities have come up with a way to almost code each of those different conditions or indications for medical supplementation so that staff don't have to write them out all the time. There's different ways to capture that. And of course, always having the option to put, a more detailed reason, or if it doesn't fall within those conditions, what the reason was. So documentation is critical, and if you're not capturing it, it's like it didn't happen. If you didn't write it, you didn't do it. So ensuring that when staff are delivering these supplemental feedings, that they're documenting that. So we know that a lot of our supplementation isn't medically indicated. Some areas of the country and the world have higher rates of this than others. Here in Cape Breton, we do struggle with a lot of parental supplementation. And I think it's so important that we try to work to understand why this choice is being made. And as I mentioned earlier, some of that antenatal education and anticipatory guidance as to expected feeding behaviors, what is normal for your baby and how they're going to feed, can really help to support the reasons why that families may choose to supplement. I think that those of us who work with families while they're in hospital have all seen some of that frustration that happens with them on the second night, in particular when baby is cluster feeding. And the family feels maybe the baby's really hungry, maybe they're not getting enough. And if they don't understand the process of breastfeeding and they don't understand why the baby's cluster feeding, we can understand why they would choose to supplement. And sometimes it's really hard to have those conversations in that moment. So I think it speaks all more to the need for that antenatal education um, and discussions about what can be expected when baby is born and how they will be supported. It is also important to support informed decision making. With these families, it's important to give them the opportunity to express their concerns. When they have that opportunity, we may find that their concerns can be um, we can support some of those concerns, and we can give them the education, the evidence that's needed to help alleviate those concerns, and maybe they will avoid supplementation altogether. If we allow them to express their concerns, and we provide evidence-based information, and they still choose to supplement, then that is their decision, and we support them in that. um, I think it's important to also, part of informed decision making is talking to families um, you know about the importance of breastfeeding and finding out why breastfeeding is important for them. Why did they choose to breastfeed? And what are their goals? Do they want to exclusively breastfeed? Explaining the benefits of exclusive breastfeeding to them is also part of that informed decision making. And thinking also about the health consequences of not breastfeeding, the risks of not breastfeeding for them, and providing that information, the impact and the cost of human milk substitutes. And for some families, they may think that tonight I'm having a really hard time. I'm going to give a supplement, but they don't realize the long-term impact of that, and really maybe they can't afford to buy that formula that they will have to buy when they go home if donor milk is not an option for them in the community where they live. um, that long-term impact of formula purchasing may be more than they can afford, and so sharing the cost of that with them is really important. And if they decide that they are not going to continue to breastfeed, letting them know that there is often difficulty in reversing that decision if breastfeeding is stopped. And so, tonight might be a really hard night, and you're having, you're really frustrated. You feel like the baby's, hungry, and listening to their concerns, um, but also making sure they know that these decisions um, there is impact to those decisions. And if they stop breastfeeding, the impact that that can have on their milk supply if their goal is to ever exclusively breastfeed. Um, and I think, it's critical for these families to have um, this support, um, to know, uh, really why are they wanting to supplement? How can we help support that informed decision? And then if they do choose um, to provide those supplementation, do they have the education and support that they need to do that safely? So part of the steps the 10 steps of successful breastfeeding is making sure that parents who choose to use formula can do so safely. And so do they have if they have the knowledge and ability to safely prepare, store, and feed their babies infant formula? And if they don't, then it's our responsibility to provide that education to them. Um, and it's important for families to feel that they were supported in their decision making. So as healthcare providers, it's our responsibility to provide that education and support, but it's also once they've made that decision, it's our responsibility to support them in that. And those are some resources that I thought are very useful and happy to share with everyone. That's it. Any questions?
Very good summary. You just nailed it in the shot.
Thank you.
Jennifer, I really appreciated how you mentioned often that the healthcare provider shouldn't assume that they know best for the parent. Just on the ward that we were at this week, that exact situation played out. An NICU nurse told us that this parent didn't need help at all or didn't require help. And when my volunteer accidentally went in and thought it was a different family, the parent had 100 questions. And it was just assumed that because they were having struggles, they were young and identified maybe as having risk factors for future parenting, they took that choice away from them. So I really appreciate that. And I think that we can always do better for our clients to make informed decisions.
Yeah, once you have those experiences with families, sharing that they felt like that choice was taken away from them, I feel like that never leaves you. You remember that. Thank you so much, everyone.
No, I thought it was fantastic. And one part that I guess I never had really had addressed with me was when moms end up offering formula or their baby gets formula and then they go try to go back to nursing after. And then they forever kind of feel like a failure because they say, like, I wasn't producing enough. I wasn't producing enough. My baby was always hungry. I
Mhm.
never connected the fact that the baby might have been overfed before, and then so they just always had sort of insatiable hunger after. And that's such a what a wonderful thing to be able to point out from the beginning, that because I don't think anybody ever says to anyone you could overfeed when using formula from the beginning. I don't think I've ever heard any, like, everybody just keeps going until, you know what I mean, there's no end. So
Yeah.
that was really, really good point.
Yeah, I think it's so important to remember, you know, if the long-term goal of this family is to exclusively breastfeed, the way we supplement has such an impact on that. And, I know that we struggle in our own facility at times if a baby's hypoglycemic and we do have to supplement for medical reasons. Yes, we need to fix that low blood sugar in this moment, but that baby has many, many moments in the future of breastfeeding, and the decisions we make today for this one supplement can impact that entire breastfeeding relationship that affects the rest of their life. So I think it's really important. Great. Thanks, everyone.